we have a small change in the program, and our next speaker is Dr. Naama Lev Cohain, the one of the brothers of those last two nice cases, and she is replacing Professor Radiologist, giving her talk about tumor of pancreas, what the surgeon needs to know from the radiologist. Please, Naama.
I'm going to talk about pancreatic cancer, but in the respect to what the surgeon needs to know. So we'll start with a few facts about pancreatic cancer. This is the fourth most common cancer-related death. It has only 4% 5-year survival, and as opposed to other cancers, which, as we know, in modern world, with improved technology and improved therapeutic options, have decreased mortality. In pancreatic cancer, compared to the previous decade or two, we have relatively stable mortality and even slight decrease. There are only 20% of the patients that are resectable at the time of presentation, and this is very crucial because we need to understand that the only curative option for this cancer is operation. The patients are divided into three major groups. The largest, as you can see, is actually the unresectable one, and only fourth of the patients are considered borderline resectable, which I will explain in a few minutes what exactly that category is. But of course, we can understand why this is happening. The lesion in the pancreas, parenchyma, has no symptomology, and it only gives symptoms, clinical symptoms, once it progresses and invades the adjacent organ or whatever is structures around it. Most of the cancers are located in the pancreatic head. The pancreatic head is demarcated by the border of the portal vein and SMV. Everything to the left of it is the body and tail, which have only third of the malignancies. Now, according to the location, of course, the surgery, if applicable, will be chosen. When we're talking about the head, the surgery will be the Whipple surgery, which, in addition to cutting off the pancreas itself, also excites there's excision of the duodenum and the biliary proximal tract. And when we're talking about lesions, in the body and tail, we are dealing with a different surgery, which is the distal pancreatectomy, and because all the vasculature of the spleen is taken out, so it goes with a splenectomy. Now, the overall 5-year survival of these procedures are not that high, as you can see, with distal pancreatectomy being a little bit less, and 30% of the patients that pass these surgeries die within 1 year after the surgery. Now, there's a problem with staging this lesion, because we don't get usually pathological staging. The only staging is based on diagnosis. And the most common diagnosis method is the CT. It has shown high sensitivity, even in small, relatively high also in smaller lesions. It is the protocol is 3 phases CT, the pre-contrast and 2 post-contrast acquisitions. The first one is not exactly arterial, but slightly delayed, about ideally 10 seconds post the maximum arterial phase, which gives the ideal delineation of the pancreatic parenchyma and the arterial structures. The delayed one is about 35 to 40 seconds later, and shows us the veins and also the potential metastatic disease. But in addition to CT, we can perform also an MR, which is not commonly performed, but of course is also useful. As we saw in the case presented before, the MR helps us, shows us very clearly how the pancreatic parenchyma should look, especially on T1, and the lesion outstands as a heterogeneous or hypointense masses in the location, as seen here. And also on post-contrast images, we can see just as with the CT, the hypoenhancement of the lesion, as well as the vasculature that is involved. Another option of imaging is the PET. As opposed to other cancers, PET is very uncommon. It has not shown to be that useful in metastatic disease evaluation compared to CT, and it doesn't help in finding the occult lesions. And the last, but not least for the imaging modalities, is the endoscopic ultrasound. Again, usually it's not indicated in our facility. It's not most of the patients are not sent to endoscopic ultrasound. The cases that are actually sent are the ones with occult disease, and it helps because the sensitivity in small lesions is useful. There are a few studies that have shown that the combination of endoscopic ultrasound with CT gets the ideal according to them, the ideal results, but it's not that commonly used. The most important thing that we need to remember when we're looking at the pancreas lesion is that we need to determine if it is resectable or not. Now, how do we do that? Let's go as radiologists to the radiology report. When we have a patient that is being scanned with a suspected or already known pancreatic cancer, we give attention to all kinds of issues. For example, we look always at the duct to see if it's dilated or not. We look at the parenchyma to see if it's heterogeneous or focally enlarged. We look at the veins and the arteries. We look at nodes, and we look at whether there's metastatic disease. But do we always look at that? And even if we do we give enough information for the surgeon? So there's a recently study that has been published in Radiology, and this group has tested whether our report how does it affect the surgeon when he's planning the surgery. What they did is they took a long period of time from their institute, and in that time, sometime in the middle, the department changed the way that the reports were written and changed from non-structural report to template reports. And the template for pancreatic cancer was this, and after this change was made, everybody had to use this template. The template included the pancreatic, the demarcation of the lesion itself, attention to the nodes and metastatic disease, and extra attention to the vessels around it. Now, what they did is they asked the surgeon 2 questions. The first question was, look at all the reports over this period of time, the structured and non-structured, and tell me how many of the cases, just by reading the report, can you decide are resectable or non-resectable, or you're not sure, just by looking at the report. The second question was, now look at the images. We know that the surgeons that have a lot of experience are very, very well equipped to deal with CTs by themselves, especially CTs with the areas that they resect. They know exactly what they're looking for. And they asked the surgeons to look at the CT and then conclude whatever conclusion they decide. And is it different from the one that they made just by looking at the report? And they found that surgeons that looked at the report that was structured made much less changes compared to the surgeons that look at the report that was unstructured. They concluded that this is probably because when in an unstructured report, not getting into whether it should be templated or not templated, but the points that were made in this report were crucial for the surgeon to decide how he will deal with the patient. So what are we actually looking for? What is actually important? When we're looking at tumor, pancreatic tumor, and tumor in general, we're always looking at the TNM criteria. And in pancreatic cancer, there's a cutoff with T4 being unresectable. And this is because it has arterial involvement. Now, when we look at these images, 2 different patients, it's clear for us that they are not surgical material. This patient has metastatic disease in the liver. This patient has very extensive peritoneal implants, which look like this in the laparoscopy. And this is not, the resection will not cure them. They have very low, short survival. Now, as opposed to that, when we look at this lesion right here, we see that it's very relatively small. It's located only in the pancreas. There's a clear fat plane between the vein and the artery. Nothing else is involved, so it's relatively clear for us this is going to be can be resected. The same in this example, we see an abrupt cut-off in the ductal dilatation, and on enhancement images, we see here the hypo-intense focal lesion, resectable material. Another example, there are two lesions here, located only into the pancreas parenchyma, no vessels are involved. But what about this? This is a humongous tumor that we see here, encasing both from the pancreas, encases the vessel, and also invading the stomach. Now, surprisingly, the stomach will not be the reason for this to not be resectable. All the local invasion this type of local invasion can be treated with surgery, chemotherapy. The problem in this patient is the vascular involvement. Now, with the continued development of modern imaging and surgical options, this subgroup has started to form, which is called the borderline resectable pancreatic cancer group. Now, in this, to categorize this group precisely is very hard. There aren't any international consensus on which patients actually meet this group or not. The main issue about them is whether or not the vessels are involved, both the arteries and the veins. This is the most common and very used categorization table that is by Andy Anderson. As you can see, it is only talking about the affected vessels, and it's referring to three subgroups: the resectable, the borderline resectable, and the locally advanced. Again, this is a very commonly used category, table, but it's not the only one. So in order to try to kind of make sense and try to make a consensus all over the world which patients meet which criteria, this very impressive group, the International Study Group of Pancreatic Surgery, has met and released a consensus statement about a year and a half ago. And they have looked at all the borderline group criteria and tried to change them, or not change them, just decide on something that is right for everybody. Now, the importance of this, why am I talking on and on about this type of group, the borderline group? Because of two issues. First of all, when we're talking about resectable margins, we always talk about clear margins or infected margins. In pancreatic cancer, there is also a subgroup here, which is referred to R1. It's the microscopic remnant group. And it has been shown that this group, it has very low survival and is relatively similar to the patients with locally advanced disease that have not done surgery. So if we're going into surgery with patients that are going to come out with R1 resectable margins, we shouldn't send them to surgery. This is a very big operation. They should not go and do it because it doesn't affect the survival so much. Another issue about pancreatic cancer, that this group, the borderline group, is the only group that will will potentially benefit from neoadjuvant therapy. Usually, patients either go directly into surgery or not resectable. The neoadjuvant therapy is dealt with only a specific subgroup within the borderline patients, and that's why it's crucial to determine which one is which. So, given their consensus, they came up with this table that does not only give attention to the vessels, but also puts in the metastasis presence or lack of. It's again the localized and resectable disease, the borderline, and the under-resectable disease. So let's start with the localized and resectable disease. Like the example that I showed you before, the lesion is very focal. There's no involvement of the vessels. There's no distant metastasis. He's going to surgery directly. The borderline group has to not have any metastatic disease. And when we're looking at the veins, it can surprisingly have any type of venous involvement. This is a diagram that shows you kind of the levels of involvement from non-involvement to abutment to total encasement. And the consensus came with a theory deciding that any thing that can be operable will go to surgery. Anything in the veins that is not operable material, which means that once we take it out, we can't do an anastomosis and a graft will not help, is going into the unresectable group. This is an example of the involvement of the SMV. My mouse went away. As you can see, this is a very common shape called the teardrop that is known with the related to the SMV involvement. Another example of venous involvement, much more diffuse, with encasement of the portal vein and the SMV. If you can cut it out and do the anastomosis, this is resectable. Another thing that the consensus has decided that patients with venous infiltrations don't benefit from neoadjuvant therapy. Now, regarding the arterial involvement, the two major things that kind of decide whether they're going to surgery or will stay in the borderline group or non-resectable is the level of the artery that is involved. Regarding the SMA, they can involve up to 180 degrees and less. And regarding the celiac trunk, whatever branches are involved, they still stay in the borderline group. But once it's involved in the celiac itself, then it's changing it to unresectable. For example, it's involving the gastroduodenal, and this is still in the borderline. Another example, we see here that the portal vein is involved, but also the SMA is slightly involved, clearly less than 180 degrees, so this is the borderline group. Another example showing the hepatic artery, the celiac itself was not involved, this is the borderline group. Now they found also that these patients are the only subgroup of patients that will benefit from neoadjuvant therapy, meaning if we find this kind of level of arterial involvement, they will go for chemoradiation treatment for a period of time, and then they will go to a laparoscopy, trying to determine whether their disease is now resectable or still unresectable. So, as I said before, the unresectable group has disc metastasis, has venous that is unreconstructible, aortic invasion, of course, and regarding the SMA and celiac trunk, the involvement is much greater, as in this case, you see that this is encasing much more than 180 degrees. This is another example of the celiac, the SMA involvement. On coronal images, you can see how the mass is involving the whole 160 degrees of the vessel, and this is clearly involving the celiac trunk. And an important issue when we're looking at the pancreas, us as radiologists, is this special space that is called the Mesopancreas space. This is kind of a theoretical, some will say theoretical space, because there's nothing really in there. Sometimes there's fat, a lot of times it's only fascia. It's located, this is how it looks in the laparoscopy actually. This is the area, it's between the uncinate and the SMA. Now why is this area important? Because when they resect the head of the pancreas, I'm not trying anything I'm not going to be able to finish, when they take out the pancreatic head, they want to keep, as we said, R0 margins, which means no residual tumor, macroscopic or microscopic. However, in this area, a lot of times, because of its very close relation with the SMA, there is very early lymphatic and perineuronal invasion. And if we see even some haziness in this area, it questions the capability of this patient to come out of the surgery with R0 margins as opposed to R1, which are much more common, as you can see here. So patients with involvement of this space will have almost 20% likelihood of coming with R1 margins. In keeping that in mind, on the same issue is the perineuronal invasion. Now, when we're talking about perineuronal invasion, for us as radiologists, we don't mean the extension of the mass itself, but rather a haziness, kind of soft tissue that is encasing the vessels. It is known to cause very poor prognosis and reduce the survival, and sadly, it has nothing to do with the size of the lesion. The original lesion can be very small, there might still be this haziness around the vessels. Now, what is it actually? This haziness, as I said, is that there are two main axes or trunks of neuronal plexuses. One of the Number 1 is located here at the celiac trunk, and number 2 is located here along the SMA. Any haziness along the vessel is indicative or suspicious to show spread along this tract, and once it's started, it automatically or very quickly continues higher up. So this is an example of a patient with involvement. You see this haziness around the celiac trunk. Another patient with this type of haziness along the branches of the SMA. And this patient has bilateral disease, involvement both here and here. One last thing about to give attention to in the report is the nodal involvement. We need to know that as opposed to other malignancies, when we're talking about pancreatic cancer, if it's a huge node, infiltrated, large, abnormal, we know for sure it's involved. However, there are a lot of nodes, or in many cases, that the CT is not informative, and the normal appearing node, on CT, will not be actually uninvolved in surgery. So the surgeons know that they cannot, we need to give our, of course, input about it, but they know not to rely based only on that, on our imaging modalities. Of course, whatever is further away will be referred to as distant metastasis already. The areas that the surgeon will always look at are along the the common hepatic artery and adjacent to the common duct. These areas here are usually, if they are affected, this will be the area to look for it. Now, all this about the malignancy, one small point that I want to mention is the vascular anatomy. When we're going into this humongous surgery, the surgeon needs to know for certain, or at least as much as he can, that he will not affect the blood supply of other adjacent large organs, in this case the stomach and the liver. So we need to be sure that to make sure that there are no abnormal or variants in the vasculature in these regions. Now, one of the most common variants is the replaced right hepatic artery, and it occurs, as you can see here, almost in 20% of the patient. When it is the artery comes out of the SMA as opposed to the common hepatic, and the problem with it and the importance of it is that it goes along the portal vein and posterior to it. And when the surgeon is planning on resecting that area, he needs to know not to hurt that vessel. Also, in some cases, it has been found to go through the pancreatic head in the parenchyma itself. So it's important to kind of clean around it. So to conclude all this tons of information, let's see how actually what important issues, if maybe all of them, are mentioned in the report that I think we should produce from every CT. So of course we need to mention the pancreatic mass itself, what's its size, where it's located, and so forth. We need to mention whether there is a adenopathy or not. Again, it doesn't conclude or say for a fact, for indefinite, if the nodes are infected or not. We need to, of course, mention if there's metastatic disease. We need to mention in very, very detailed, give extra attention to the vascular involvement. Which vessels, the artery or the vein, up to what level, the level of haziness, if we're suspecting the perineuronal involvement, and again, that space behind the uncinate, thrombosis, of course, and the aberrant anatomy. Thank you.
I want to thank especially Naama Lev Cohain. I don't know you, but I really appreciate. I've been told you are one of the rising stars of radiology in Israel. I start to believe it really clearly. Thank you so much, because you have to know that she prepared it at the very last moment, because Arik, also couldn't make it, and I really thank you for that, and it was